Thank you, Dr. Tuttle, for that kind and generous introduction. So I think um, this topic is kind of quite close to my heart. One of my first global health experiences um, after medical school and completing my training in the US was in Kenya, actually. In the very place that I am right now. I came here 4 years ago as a palliative medicine fellow. I spent a month here, and one of the things that really touched me was a 15-year-old boy with an aggressive lymphoma, and you could see all the challenges that that kid went through. Um, I was, we were as a palliative medicine team, we were asked to see him to manage his pain. He was in the hospital for like 3 or 4 months. And just a week ago, he had finally gotten a diagnosis. He was initially misdiagnosed as having an aggressive sarcoma, and he was stuck in the hospital for all this while because it was in his limbs. He could not go home. Um, I think one of the things that kind of, really, really struck me is how we were able to help this boy. We actually started our hospital's first intravenous morphine drip, and we were able to really kind of, um, you know, palliate his symptoms. So with that, I wanted to kind of, start off the topic for today, covering palliative care from a breast cancer perspective in low resource settings. Next slide, please. So this is loosely going to be how I'm going to structure my talk, starting from what is like the spectrum of palliative medicine when it comes to cancer. Um, and also, what are some of the needs of a patient with metastatic breast cancer? And then what are some of the challenges and how we can kind of mitigate some of those? Next slide, please. So, cancer care in 2026, what is typically our approach? And Dr. Tuttle, if you could just click the mouse pointer once. So a patient typically presents with um, symptoms. And these are cancer patients we're talking about. So symptoms, so either a patient he or she comes in with symptoms or is kind of screened for a cancer. And typically, in low middle income countries and under-resourced settings, you typically see them presenting with symptoms. Um, next click. So one more.
Sorry.
Sorry. I think you can just keep pressing.
Okay, I'll keep going. You
And
tell me when
yes,
to
just
stop.
just keep going. Um, so when a patient presents with either symptoms or is screened for a cancer, the next phase is the diagnostic phase. And following this, these patients kind of see a specialist, which is, one of the fill in the blanks. So surgical oncologist, radiation oncologist, a medical oncologist, or a hematologist. And then there are two possibilities here. So, after seeing the specialist, patients get the treatment, and then you have two responses. So one of them is the cancer response, and the other is the cancer does not respond. So when a cancer responds, typically we call the patients um, a survivor. And it is possible that so within the survivors, the cancer can either come back or the survivor can have a second cancer. So which kind of feeds back to the fact that, the cancer needs more treatment. Or it is in the metastatic setting. So this is where, palliative care and hospice kind of comes into the picture. Next slide, please. So why is it important to look at palliative medicine in breast cancer care? So as you can see on this in this heat map on the incidences of cancers in women, um, it's heavily it's breast cancer. Breast cancer is the most common cancer in women in most countries worldwide. And the other thing is that the fact that when these women present, it is typically with symptoms. So we are talking about locally advanced disease, patients with, inflammatory breast cancer or metastatic disease at presentation. Typically, from the data, from some prior data, about more than 50% of them present with, breast cancer in its advanced stages. And this might actually be an underestimation. This number might actually be even more. Next slide. So then comes the question of what exactly is palliative care. So the WHO defines palliative care as an approach which improves the quality of life of patients and their families facing the problem associated with the life-limiting illness through the prevention and relief of suffering by means of early identification and assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So the word palliative has been around for a while now. It previously used to, it means that it is something that is used to treat symptoms without treating the underlying cause. And the term palliative care actually became kind of popular in the 70s, where it was used to be substituted for hospice care. And it was at somewhere around this time frame when the word supportive care also came into the picture. So the word supportive care has been interchangeably been used with a milder, softer version of palliative care. But the origins of supportive care came from, giving heavy chemotherapy back in the 1960s and 70s, and those patients requiring transfusion support, also requiring support for, severe intractable nausea and vomiting, and so on and so forth. And then there is hospice care, which is defined by the American Cancer Society as a special kind of care that focuses on a person's quality of life and dignity as they near the end of their life. And in this case, it is typically like the last 6 months of their life. Next slide, please. So I mentioned the two words, palliative and supportive care. They arose in different contexts, as I mentioned on my previous slide, and then they have now kind of intertwined. And then the other thing on this is, next slide, please. So a study at MD Anderson revealed that the word palliative care has kind of a stigma attached to it. So the folks at MD Anderson did a study some time ago, and they saw that when they changed the service's name from palliative care to supportive care, they saw a 41% increase in consults. And being a fellow and kind of interacted with some of the palliative medicine physicians, it doesn't, in practice, they don't typically mind using the word palliative care or palliative medicine. But I guess the numbers here show, that there is kind of a stigma attached to the name. Next slide, please. So what is the paradigm of a typical breast cancer patient, and the relationship of palliative care in terms of the therapies that they receive for their breast cancer? So from the time of diagnosis, the patients kind of, are offered disease-directed therapies. which is in the top portion of this cartoon. And then the yellow piece is the involvement of palliative care. So you can see, some patients may not have as many symptoms right at the start, but as the disease, if there is disease progression, the involvement of the palliative care needs of the patients kind of increase side by side to the extent where they reach quite close to the end of their life, where the hospice kind of comes into the picture and um, no disease-directed therapy is offered to the patient. And importantly, the hospice care also not just covers the end of life, but it also covers, bereavement following the death. Next slide, please. This slide is just to kind of show the difference in approach of the traditional model of palliative care and the current one in the bottom. So previously, there was a sense that, there is a point in the patient's trajectory when when disease-directed therapy switches on to just focusing on symptom management. But it's no more the case now, as you can see in the bottom cartoon, where there is a need for palliative care to be involved early and aggressively in order to kind of manage some of the symptoms and improve the quality of life. Next slide, please. So the question of when do you time, palliative care? And this was the landmark study by Jennifer Temel back in 2009. And this was one of the landmark palliative medicine trials. So she um, uh, took patients with metastatic non-small cell lung cancer, and um, they were divided into two cohorts. One of them got early involvement of palliative care, ideally around the time of diagnosis, and the other group got the usual care, where palliative care was involved when they needed to come in for management of symptoms and goals of care. And you can see two main outcomes of this study. So one of them was the patients had better quality of life scores, as you can see um, on this graph, and the other one was the survival. So this study actually showed an improvement in survival in those who got early palliative care. As you can see, there was like a 2.5 month survival advantage, and the curves kind of separate out. Next slide, please. And then there was the ENABLE trial. So this was basically kind of delivering palliative care in primarily kind of rural population. So this was this set of trials was conducted in Dartmouth about 20, 30 years ago. And it showed that the intervention of involving palliative care was definitely kind of improving the quality of life. So that one was the ENABLE 1 trial. And then came out the ENABLE 2 trial, which was primarily a nurse-led phone-based intervention, where these palliative trained nurses were delivering care via mobile health applications, and trying to reach some of those patients for whom it is hard to kind of get to the main cancer centers. And this study found that there was a higher quality of life that was noted in these patients. And the ENABLE 3 was a subsequent follow-up study of this, where they looked at early versus delayed integration of palliative care. In the previous two trials, it showed the feasibility of doing this, as well as they showed that it was improving the quality of life. In the ENABLE 3, they looked at early versus delayed involvement of palliative care. And in this study also, they saw there was a 15% OS or survival benefit at 1 year. Next slide, please. So what is the impact of advanced breast cancer, sorry. So you can keep it under three buckets. So one of them is going to be kind of toxicities of the treatment that patients receive. So whether it comes to neutropenia or diminishing bone marrow reserve. And then you have symptoms from the cancer itself, and that could be fatigue, complex pain, ascites, lymphedema, and bad wounds. And then you have the psychosocial impact of breast cancer, when you have changes in the mood and existential crisis, and the need for having a serious illness conversation. Next slide, please. So what are the needs of these patients? So again, this can be kept under three buckets. Um, and who are the folks who are delivering this? So there is primary palliative care, and then there is more specialized palliative care. You could think of an oncologist as a deliverer of primary palliative care. So when it comes to kind of symptom management, um, not just managing pain, but also other symptoms, including symptoms from the hormonal therapy. Um, and then you have kind of addressing the need of the psychosocial symptoms that these patients might develop, and the need for having kind of a goals of care discussion, kind of sharing information of the trajectory of the cancer, and kind of having discussions, best case, worst case scenario. So next slide, please. So next, coming on to what are some of the challenges that patients that the health system might face in the implementation of palliative care interventions in these settings. Next slide, please. So the first one is pain is one of the major symptoms in breast cancer, metastatic breast cancer. In pain can be due to several reasons. One could be bone mets are very, very common in breast cancer. So the there is prevalence of a lot of inequity globally when it comes to kind of access to an important class of drugs used to manage pain, and that is opioids. So there's a 10-9 pain dictum where the richest 10% of the nations possess 90% of the morphine. And you can see here on the left side, the access to the inequity that's in existence when it comes to access to opioids for pain management. In the red, you can see the United States and Canada, along with Western Europe and Australia, where the access morphine is very, very accessible to these patients in these regions. And on the right side, you can see opioid overdose deaths. The darker the color, the more deaths due to opioid overdose. And here also you can see the US with the opioid crisis is one of the darker shades of brown. What are some of the reasons why this happens, especially with access to opioids? As well as at the system level and at the patient level. So at the system level, you could think of it is hard to kind of regulate the use of opioids, and then there is the lack of training of how to kind of use opioids. At the patient level, there is kind of cultural uh, issues that are at play when it comes to there is a notion that pain is something that the person needs to live with, and not something that needs to be addressed. Um, and then there is also fear of addiction. Next slide, please. And then there are misconceptions. So there is a notion that palliative medicine is equal to death or end of life, which is not necessarily the case. And then there is the concept of diagnostic non-disclosure. This is basically what this terminology means is that there are regions in the world where they don't want to, the patient does not want to know what the diagnosis is. They will get through the the treatment of their cancer not knowing what they are facing or what cancer is. And this is seen in a few cultures. I have seen it, I've had a personal experience with this, where one of my young cousins who died of metastatic breast cancer, and my dad was taking care of him, taking him to the doctors. And one of the things that I noticed was that my dad was hiding the diagnosis from my cousin who had breast cancer. Um, and when I asked my father, he said, if we tell him what the diagnosis is, it will bring down his hope and he will go into depression and he will die. So this concept is there in some cultures. And then perception of death is different in different cultures. And it's a taboo topic in several cultures. Next slide, please. The other thing is lack of quality workforce education. So by this, I mean there is a lot of heterogeneity when it comes to the healthcare curriculum, particularly in LMICs, where basic palliative care curriculum is not integrated into their basic curriculum. Um, when we think about who drives palliative care, we think about specialists and like non-palliative specialists. Um, and both are important to any health system. And it is seen that education and mentorship in palliative care has shown to improve palliative care delivery. Next slide, please. So this is a big topic. So limited resources and lack of research funding. So there is lack of funding for cost-effective interventions in LMICs when it comes to opioid, when it comes to access to radiotherapy. I can tell you that there are at least 3 or 4 sub-Saharan African countries which do not have access to radiotherapy. There are also some places in sub-Saharan Africa that do not have a single oncologist in the country. So this happens, when the resources are scarce and the budgets are kind of depleted. Palliative care is lowest on the list of priority. And when it comes to research, even in high-income countries, there is very little funding that goes towards palliative care research. And most of these is in high-income countries. There is the research within palliative medicine is basically non-existent in LMICs. Next slide, please. The last section of this talk, what are some of the pragmatic solutions to some of these challenges? Next slide, please. So there is a 5S framework to kind of improve access to palliative care in oncology. So these are the 5 S's. So staff, stuff, space, systems, and synergy. So staff is basically like the workforce, and what can we do to kind of help improve the workforce in palliative medicine. And then the second one is stuff, which basically means the resources or the commodities. So we can think of things we can think of is access to drugs, such as opioids. And then you have interventions that can help palliate some of the symptoms, such as securing a radiotherapy unit. The third thing is space. So like a dedicated space for, carrying out these interventions, whether it's a palliative medicine clinic or it's a space for the radiotherapy. And then fourth is systems. So how can we kind of optimize the at the health systems level, how can we optimize the referral pathway? Whether it be like developing a referral network or building an EMR that can help with easier kind of coordination. And then how can the last one is synergy? How can palliative medicine kind of interact with other disciplines in oncology? Within oncology, a good example is how can palliative medicine interact with medicine, radiation oncology, and surgical oncology. Next slide, please. So staff, as I said, it's the basic workforce. So um, kind of having systems in place where there is some kind of basic palliative care curriculum for all healthcare providers or practice providers in oncology. And then you need subspecialty training in order to create leaders in the field who will eventually kind of drive service development and strengthening of the referral system. Um, and then improving access to radiotherapy, which kind of hinges on workforce training. A good example of this S is next, please. Yes. So in Kenya, we have a clinical officer training program. So clinical officers are basically like nurse practitioners. Over here at MTRH in Western Kenya, where I am currently, we have this training program that was opened like 3 or 4 years ago, and we have currently our third cohort of these nurse practitioner equivalents who have graduated from the program, and most of these um, clinical officers go into the community and deliver care in some of the um, uh, community level hospitals. Next slide, please. And then we have access to drugs and radiation therapy. And a good example of this is, next slide, please. So Rwanda actually kind of serves as a good model for this. So what actually drives the success of Rwanda's palliative medicine program is back in 2011, they integrated and prioritized palliative care within their national cancer policy. And you can see the fruits of this, where they were able to kind of launch local production of morphine. And recently, a few years ago, it kind of also launched its cancer center, which houses its radiotherapy unit. Next slide, please. Next slide. We are in the same slide, Dr. Tuttle. So space is physical infrastructure to kind of deliver the services. And it includes radiation, hospice units, and dedicated area in primary care and the hospitals. And one of the good models is Hospice Africa, Uganda, and introduced in 1993 to kind of cater to the hospice patient population, kind of keeping in mind what are the resources available locally. Next slide, please. Then comes the system, kind of strengthening the health system by optimizing the referral pathway. And this basically kind of utilizes mobile services for healthcare delivery, teleoncology, and utilizing the EMR. And a good model for this is next slide. So in Western Kenya, there is the use of telehospice, which is being used for symptom management for those who don't have access. One thing that is seen is Western Kenya is big. On an average, patients travel 150 to 200 kilometers to get to a cancer center. So an intervention such as this is very innovative, very unique. Next slide, please. And lastly, how can palliative medicine and oncology kind of synergize? Next slide. And a model for this could be, having the palliative radiotherapy kind of synergized with the medical and surgical oncology services. Next slide, please. And this is my summary slide. So in LMICs, breast cancer is the most common cancer among women, and they typically present with locally advanced or metastatic disease at the time of their presentation. Next. Early involvement of palliative medicine in patients with advanced cancer improves quality of life and survival, even in under-resourced settings. Then next. Challenges to delivery of high-quality palliative care in low-resource settings include inequitable access to opioids, misconceptions, lack of high-quality workforce education, and lack of funding. And lastly, the 5S framework is a good tool to improve access to palliative care. And I will turn it over to Dr. Tuttle here.
Well, thank you very much for a very comprehensive overview of palliative medicine in low-income settings. We'll do the questions at the end if we have time. I will see if I can now get my slides on. Might just take me a second here.
Thank you, Dr. Tuttle, for moving my slides.
Sorry for doing very good.
It was a task. I'm sorry.
No, I'm sorry it didn't work out very well. Can you see my slides, everyone? All right, you got the slides. So I'll introduce myself. I'm Todd Tuttle. I'm a surgical oncologist here at the University of Minnesota and director of the Global Surgery Program. I'm going to continue on Dr. Rangoonwala's comments, and I'm going to talk about surgery and stage 4 breast cancer. So I'm going to cover palliative surgery, the local treatment of de novo stage 4 breast cancer, and the surgical treatment of distant metastatic disease from patients with stage 4 breast cancer. So surgery can play a very important role in the palliative treatment of patients with advanced breast cancers. And this problem is unfortunately more common in low and middle income countries where you have more patients with advanced breast cancers than we do here in the United States. But surgery can be absolutely key to relieve pain, to stop bleeding, to reduce or control infection. Usually the operations are mastectomies, but they don't have to be. And importantly, in palliative treatment, surgical palliative treatment must be done in a multidisciplinary fashion, because if you do a mastectomy on these patients, you are going to interrupt their systemic therapy for their systemic disease. But nevertheless, very important role, particularly in resource-limited countries. So one of the more controversial issues regarding surgical management for stage 4 breast cancer is this: can local regional treatment improve overall survival among patients with stage 4 breast cancer? Now I'm going to give a case presentation. This is a 36-year-old woman. She noticed a right breast lump while she was pregnant. She had an ultrasound at that time, which demonstrated a 2.7 centimeter mass in her right breast. Her axillary lymph nodes looked normal by ultrasound and by physical examination. She had a biopsy of this breast mass, which demonstrated grade 2 invasive ductal cancer that was triple positive. She saw medical oncology. They initiated dose-dense adriamycin and Cytoxan. She delivered her baby at 37 weeks. After she delivered, she had a more formal workup, including a CT scan of the chest, abdomen, and pelvis. This showed an indeterminate lesion in her lung, probably benign, and a 1.3 centimeter liver lesion. Her bone scan negative, brain MRI negative, and unfortunately, a biopsy of her liver demonstrated adenocarcinoma consistent with a breast primary, and this was also HER2 positive. So she had isolated metastatic disease that we could tell to her liver. This is her CT scan, and you can see the mass in the left side of her liver, about 1.3, 1.4 centimeters in size. So after this biopsy, she finished adriamycin. After she delivered, she was treated with paclitaxel and trastuzumab. On liver MRI, this mass decreased in size. On breast MRI, it was really hard to see any residual tumor. So here she is now, no real breast symptoms at all, no real symptoms in her liver. Should we operate on her breast to improve her overall survival? There are a number of issues for doing local regional therapy for patients who present with de novo stage 4 breast cancer. One is the timing of systemic therapy and local regional treatment. Is there a role for breast conserving surgery? If so, what's an adequate margin? What do we do about mastectomies, bilateral mastectomies, reconstruction? For patients with stage 4 disease, is there a benefit for radiation therapy after surgery? And what do we do about the lymph nodes, which is a controversy even among patients who do not have stage 4 breast cancer? Well, first we'll talk about retrospective studies. And there are multiple retrospective studies that have demonstrated improved survival rates for patients with stage 4 breast cancer with local regional therapy versus systemic therapy alone. There are a number of possible explanations for this observed survival advantage in retrospective studies. There could be augmented immune regulation because there's less tumor. There's decreased metastatic potential by eliminating breast cancer stem cells and eliminating the seed source for new metastasis. Perhaps chemotherapy is more effective by not having the primary tumor. And there's a decreased likelihood of development of potentially resistant cell lines. These are possible explanations for the observed survival advantage in retrospective studies. I think it's more likely selection bias. If you look at these retrospective studies of local regional therapy versus systemic therapy alone, those patients who had surgery were younger, healthier, they had lower tumor volume, and they were more likely to respond to systemic therapy than patients who were treated with systemic therapy alone. Fortunately, we have several randomized clinical trials that I'm going to go through. The first is the Mumbai trial. And this trial had patients with de novo stage 4 breast cancer. They were randomized to local regional therapy versus no local regional therapy. There were 350 patients total that were randomized. The median overall survival was not significantly different between local regional treatment and no local regional treatment. And you can see there's really no trends in these survival curves. So the median survival, 19 to 20 months. There are problems with this Mumbai trial. This is a single center study. The median survival rate of 19 to 20 months is very low. And the vast majority of patients with HER2 positive breast cancer did not receive Herceptin. Let's look at a second randomized trial, MF07-01. This is a multi-center prospective randomized control trial from Turkey. 274 patients. Patients were randomized to local regional therapy followed by systemic therapy versus systemic therapy alone. This trial did show an improved survival benefit with local regional therapy, as you can see in this graph, with the blue being local regional therapy. This trial, however, has an important limitations, and they can be found on table 1. The problem with this trial is they did not do a very good job of randomizing patients. So there were significantly more patients with favorable tumor characteristics in the surgery trial. ER-positive breast cancer is 85.5% in the local regional therapy group versus only 72% in the no local regional therapy group. We also noticed differences in the rates of triple-negative breast cancer, lower in the surgery group, and bone-only metastasis higher in the surgery group. So all of these factors and not doing a good job of randomizing patients really, I think, led to the observed findings in this randomized trial. Trial 3, the ABC-SG28 or positive trial. This is a prospective multi-center trial from Austria. Patients were randomized to local regional therapy, followed by systemic therapy versus systemic therapy only. Small trial was stopped early because of poor accrual, but no improved overall survival benefit with local regional therapy. Now, the most important trial, I think, is EA2108. In this trial, adults with local regional breast cancer and distant metastasis were treated with systemic therapy for at least 12 weeks, and these treatment decisions were based on NCCN guidelines. For those patients who had no progression, they were then randomized to either local regional therapy plus continued systemic therapy or systemic therapy alone. Local regional therapy could be either breast-conserving surgery with negative margins or mastectomy, and radiotherapy was administered according to NCCN guidelines. And patients were stratified by the number of organ systems and the marker status. Delayed local regional therapy was allowed if needed for palliation. The primary endpoint of the study was overall survival. 70% of the patients underwent mastectomy. We found no overall survival benefit in this study. This is the curve on the left. And again, you can see these two curves overlap with really no trends at all. There was an improvement in local regional therapy, or local regional control, as you would imagine, with those patients getting treatment. Furthermore, the authors found that there were no subgroups that benefit, including age, which is important when we talk about the next study, BMI, tumor nodal status, number of metastatic sites, and the disease type. EA2108 also looked at quality of life measurements, and there was no difference between local regional therapy and systemic therapy at all time points, except at 18 months, where systemic therapy alone was associated with an improved quality of life. Otherwise, they were the same. So this is a very strong study. It's prospective, multi-center. Patients initially had systemic therapy, and treatments were based on NCCN guidelines. The authors conclude our results do not provide any support for the use of early local regional treatment as a means of achieving improved survival. And finally, there's the JCOG 1017 study, a prospective multi-center trial from Japan. Patients had systemic therapy first, and then if no progression, they are randomized to continued systemic therapy or local regional therapy, very similar to the design of EA 2108. 407 patients, no improved overall survival. There may be a potential benefit in premenopausal patients. The authors concluded that primary tumor resection to improve survival is not recommended for de novo stage 4 breast cancer. So we had these 5 prospective randomized trials from different countries. Only one trial showed an overall survival advantage, and that was from Turkey, but this trial had some significant randomization issues. Next, I want to switch and talk about the surgical management of distant metastasis. First of all, surgery does play an important role in palliation of patients with distant metastasis. I had a patient who had a HER2-positive breast cancer. Within a year, she developed a cerebellar metastasis with significant pain. She had to pull her car over. She underwent a craniotomy and resection of this metastasis, and she is alive 25 years later with no brain recurrence. She still has distant metastatic disease, but a 3-hour operation provided significant palliation and long-term palliation for her brain metastasis. And I think there's certainly a role for palliation for patients with brain metastasis, skin metastasis, nodal metastasis to improve overall quality of life. But a different question is, does surgical treatment of distant metastatic disease improve overall survival? Let's look at case number 2. A 46-year-old healthy woman noticed a spiculated right breast mass. She had an ultrasound which demonstrated a 2.5 centimeter mass with an abnormal axillary lymph node. She underwent a biopsy of the breast, grade 3, triple positive breast cancer, and her lymph node was positive as well. She had genetic testing, which was negative. She received neoadjuvant chemotherapy with Herceptin. She underwent a lumpectomy and then a tagged sentinel node biopsy. She had 9 millimeters of residual breast cancer and still a small focus in her sentinel node. She received breast radiotherapy, Herceptin, endocrine therapy, and then 2 years later had a PET CT scan showing an isolated mass in her liver. This was biopsied, was again a HER2-positive adenocarcinoma, consistent with her breast primary. So the question I raise is, after systemic therapy for her stage 4 disease, should she have liver-directed therapy? Should she have a liver resection or a radiofrequency ablation or some ablative procedure to her liver? We don't have prospective randomized trials. We have a lot of retrospective data. For example, for patients with liver metastasis, a systematic review of 19 studies that included over 500 patients, the median overall survival after liver resection for breast cancer was 40 months with a 5-year overall survival rate of 40%. These are highly selected patients. There's no comparison group. Similar for lung metastasis, a meta-analysis of almost 2,000 patients, all retrospective data, 5-year survival rate after resection of lung metastasis, 46%. Again, all retrospective, no prospective randomized trials. So we have no prospective randomized trials for surgery of distant metastatic disease, but perhaps we could look at published prospective randomized trials that we have for radiotherapy for distant metastasis and use that as a surrogate to determine whether or not surgery would be useful. Let's look at the CURB randomized clinical trial. In this trial, which included patients with non-small lung cancer and breast cancer, There were 47 patients with breast cancer. Patients were randomized to standard of care chemotherapy or standard of care chemotherapy plus stereotactic body radiotherapy. There was no difference in progression-free survival between those patients who received radiotherapy versus systemic therapy alone. Low survival rate. In the Extend randomized clinical trial, there are patients who had less than 5 distant metastatic disease. This is all breast cancer patients. They were randomly assigned to, again, standard of care chemotherapy plus definitive local radiotherapy versus chemotherapy alone. Only 21 patients in this trial, and there was no difference in progression-free survival or overall survival with or without radiation therapy. Now, you could argue that radiation therapy isn't as good as surgery. However, for those sites that were treated with radiotherapy, the local control rate was 100%. Surgery can't do much better than that. The problem is that patients started getting metastasis at other sites. In the United States, there's this kids game called whack-a-mole, where there's a bunch of, it's like a table game, and these rodents pop up out of the ground, and the kids take a mallet and they hit this mole, the mole goes away, and then another one pops up somewhere else. And this study and these studies of the surgical treatment of distant metastatic disease often reminds me of the whack-a-mole game. So, in conclusion, surgical palliation should always be considered for patients with either primary local disease in the breast or even at distant metastatic sites. However, for patients with de novo stage 4 breast cancer, I don't recommend local regional therapy to improve overall survival based on the data that we have today. Similarly, surgery for distant metastatic disease is really not recommended to try to improve overall survival. Before we take questions, I want to talk about our next Global Breast Cancer Seminar, which will be May 5th. This will be our 12th one of this year. We'll take a break over the summer, and we'll start up in the fall. So the May 5th one, which is Cinco de Mayo, you are going to be the presenters. So we want to have our participants here to present their cases, patients that they've seen. And we're asking you to have a series of PowerPoint slides where you include demographic data, presentation, family history. If you have imaging, put it on there, pathology. And if you have a specific question of why you're presenting this case, list it. And then send the PowerPoints to me, and then we'll have you present them at this May 5th conference. And then we're going to invite all of our presenters over the past year to comment and give advice on your case. So you can get multidisciplinary, international expertise advice on your patients. So send me your presentations by May 28th. This is the email, and I will, and we'll send out reminders, and hopefully this will be a very interactive seminar to finish our year before starting up again in the fall. So thank you all for your attention.